David Liew here from Melbourne, Australia, reporting on ACR Convergence 2024. And I wanted to talk a little bit about cardiovascular risk and JAK inhibitors, just in case we haven't heard enough about it. Actually, there was surprisingly little overt mention of oral surveillance at this meeting. There's a lot of data about JAK inhibitors and cardiovascular risk, and actually other therapies in cardiovascular risk. And that's what I want to talk about today. So one poster that I saw on the Monday, from the Monday session of posters was looking at self-reported international data from the FAERS database. So that's spontaneous pharmacovigilance reports looking at side effects from therapies. And so you can look at how reports come in from variously and how they relate to the proportions of other reports they have for any given medicine, and then see whether there's a disproportionate amount for a certain adverse event for a certain medicine. So that's commonly done with FAERS data. And so what we can do is look at our rheumatic disease drugs and then look and see what the risk, whether there's a disproportionate reporting of myocardial infarction, stroke, angina, cardiac failure. And so investigators from Louisiana did just that, looked at FAERS data and looked at our medicines. And yes, for tofacitinib, we saw some increased reporting odds ratios for myocardial infarction of about 1.5, stroke from 1.6, not so much for angina or cardiac failure. But do you know what else was up there? And in fact, as far as myocardial infarction was concerned, certainly exceeded that: prednisolone. And I think that's always a missing part of the discussion. So as much as we talk about oral surveillance as controlled trial environment versus TNF inhibitors, where both therapies had good effect, similar effect, and so therefore really had similar steroid exposure in that controlled trial environment, the reality is that the reason why we have DMARDs is to try and reduce down steroids, and steroids are actually a big part of what conveys cardiovascular risk. So we actually saw another abstract from the last day oral sessions, abstract 2673, which came from colleagues in British Columbia, looking at reported data there about steroid exposure, what happens when you stop steroid exposure, and then cardiovascular risk after that. So they looked at 28,000 steroid exposures in rheumatoid arthritis patients. And what they saw was that actually there was a substantial increased risk still in patients after they'd stopped steroids. So if you'd only been on steroids for 6 months and then stopped after that, you still had 1.5 years of cardiovascular risk after that, for cardiovascular death. If you were on steroids for 12 months, 3.5 years of risk. 24 months, 10 years of risk. Now, there are some caveats on these data, and there's a risk of residual confounding there, and it may not all be entirely the steroids. But certainly it's a good reminder that as much as we're worried about the relative cardiovascular risk from different DMARDs versus other DMARDs, the real cardiovascular risk we should be concerned about is prednisolone. For plenty more on JAK inhibitors, you know where to go, rheumnow.com.